I'm really privileged to be here to speak to you a little bit about the work that I do at the Center for Health Information and Analysis, and hopefully to give you just a glimpse of perspective on how we look at the world of healthcare and some of the issues that Dr. Dunlop just described. My name is Aron Boros. I'm the Executive Director of the Center for Health Information and Analysis. The center is one of the two state agencies that were created last summer as part of Chapter 224, the cost containment bill that was created. Today I'm going to be speaking about the high cost of healthcare, and I'm going to present it as a sort of a quick case study. So hopefully that'll be a little bit entertaining. So like I said, I'm from the Center for Health Information and Analysis. What we do is provide an information baseline for understanding and monitoring the healthcare system. Our sister agency, the Health Policy Commission, takes that information baseline and turns it into recommendations and evaluation of the system in a more regulatory or policy-oriented way. So what we do is provide a reliable, meaningful source of information that the Health Policy Commission, other policymakers, including policymakers at the medical society itself, can really rely on. The two adjectives we use to describe our work are reliable and meaningful. So reliable in that it's accurate and timely and that it's sort of beyond impeach, and meaningful in that it actually helps you do your jobs and helps others make sense of the healthcare system, which, as you know, is phenomenally complex and phenomenally challenging to improve due to all of the interactions and complexities. So our approach is to privilege that reliability and meaningfulness, and the way we do that is through an engaged, transparent operation. So we work on a very regular basis with providers, insurers, other kinds of advocates and stakeholders, as well as other parts of the state government. And we work very hard to make sure that we're not surprising anybody, that we're getting it right. So what that means is that we work with the medical society, with the hospital association, with health plans, and so on. And we do that on a literally every day and every week basis so that they understand what our agenda is, they understand how we do our work. And then when we publish work, we also publish the data and we publish our methodologies so that there's a real sense of familiarity and understanding of what we're doing. Now, I won't say that the Medical Society or the Hospital Association agrees with us every time we take an approach, but I am proud to say that we have a reputation for being transparent, open, collaborative, and really working through that approach to build the credibility of the work that we do. So the chief complaint in Massachusetts truly is affordability. So your medical society published a survey in May, and they asked Massachusetts residents, what do you think is the single most important healthcare issue facing Massachusetts today? 45%, the red men on your map on the screen, named affordability as the most important healthcare issue facing Massachusetts. That's more than quality of care, access to insurance, access to care, even Obamacare, all combined. So one of the really heartening things out of that survey is that large majorities expressed confidence in the quality of their care and their access to care in Massachusetts. I don't think we should rest on our laurels with respect to quality and access, and there's always more work to do, but more people indicated that affordability is the chief complaint than any other issue. So if you look at the cost of healthcare in Massachusetts, it will come as no surprise to most of you that for a long time we've had costs here well above national averages. So our patient today is MA, the 225-year-old Commonwealth, and presents with this high cost of, chronic high cost of healthcare. And a couple of notable things. So in 2009, we spent in this Commonwealth about $10,000 per person on healthcare. That's your premium coming out of either your paycheck or the premium that you pay directly, plus it's the money we spend on Medicare and Medicaid for Massachusetts residents. $10,000 per person. My family of 4, that's $40,000. That's $500 per person more than just our New England neighbors. And it's $2,500, and that's what you see on the screen, more than the United States average. So if you think about this, just to give a little sense of motivation, if we were to bring the Massachusetts cost just down to the national average, we would be saving $10,000 every year for a family of 4. The red arrow on your screen indicates Chapter 58 that passed in 2006. This was Romney Care, the large coverage expansion that you were an instrumental part in and was really, as you know, set a precedent for the country in how to approach the coverage challenges in a uniquely American way. What you can see here is that the coverage expansion neither was designed nor successful in reducing costs. Costs really continued to increase in Massachusetts despite that coverage expansion. Since then, the legislature has passed three additional laws to really think about quality and cost in a more aggressive way, culminating with last summer's Chapter 224. So if looking at our case study, we want to do some differential diagnosis. What are some of the possible reasons why our costs are so much higher, both in the rest of the country and the rest of the world? So we could look at the increasing age of our population, and that's true. It's about half a percentage point a year, age driving increased cost. We're a wealthy state. It's no coincidence that Massachusetts is wealthier than the rest of the country, also spending more on healthcare. Also no coincidence that the United States is a wealthy country, spending more on healthcare than other countries. But one of the real challenges about that explanation is that we may be spending more, but it's not clear we're getting a lot more. It's not clear that the huge amounts more, so for instance, Massachusetts is 36% more expensive than the rest of the country, that those huge differences are really delivering 36% more health or better outcomes. And so we have to continue to keep an eye on quality and outcomes, as well as looking at ways that we can reduce cost, increase efficiency, so that we're not hurting patients at the same time that we're trying to free up resources for other investments. Other potential diagnoses, malpractice. Certainly there are huge costs of malpractice insurance, and more importantly, there's huge costs of defensive medicine and other ways that your practice is distorted because of the risk of malpractice complaints. That's a very real cost, but the best economic estimates suggest it's about 3% of total healthcare spending. So something definitely worth addressing, something that we need to continue to keep attention to, and something that was addressed last summer a little bit with respect to disclosure rules in Massachusetts, but not the major story in what's going on in the healthcare system. There's also an issue of administrative costs. So all of you know very well the burden of administrative costs. There was a study by Robert Wood Johnson a few years ago that suggested that in physician group practices, there were approximately $70,000 per physician in administrative costs for prior authorizations and formulary management, and certainly billing and coding, which is a huge one. Again, a really important thing to work on, something that's actually near and dear to my heart. 10% of the premium cost goes to insurer premiums. Billions and billions of dollars of provider costs go to administrative costs as well. But again, it's an important role, but not driving cost increases, not driving the differences between the blue and the green line on the screen. So what I believe is really driving the difference between the blue and the green line and really driving the high cost of healthcare in Massachusetts is what I call a system designed for more. So you can see here, we've got lots of different players. We've got patients on the left. We've got their employers on top, who they're usually accessing insurance through their employers. We've got insurers on the right, and generally the employer is the one purchasing insurance and making insurance decisions on the behalf of their patients. And then, of course, we have providers in the bottom. And what's missing from this diagram, and should really be added, is the government. And so the government is both an employer, an insurer, a provider in some cases, and, of course, has an additional regulatory impact on all of these parties. So the red arrows here really indicate the ligaments between our organ systems here. And that's where a lot of the system designed for more happens. So let me walk through that a little bit one by one. So with respect to the relationship between the patient and the employer, we have a situation where the patient, in this case an employee, is only paying a small portion of the premium. Why does that matter? Well, if an innovation comes from an insurer and they say, I could take 15% out of your premium, but in exchange you're going to have a limited network, or you're going to have tiered networking, or we're going to have different kinds of patient incentives that might restrict their choices. The patient says, Well, I'm saving 15% only on my portion, but I'm bearing the full cost of the limited network, the full cost of restricted choices. So they don't actually get to weigh the costs and the benefits appropriately, which encourages them to ask for and demand from their employer richer and richer benefits. Same side of the same coin is employers. So health benefit choices at employers are generally made in the HR department. What's the HR department's job? Their job is to attract and retain their best employees. So they're risk averse. They're not going to mess around with their health benefits just for the hope that they might be able to reduce costs in some small way. Those HR departments are charged with making their employees happy. So again, it's an incentive that's driving the system to create more care at higher price. Before I move on and talk about providers, I want to make the point that patients are acting rationally and intelligently and ethically here. Employers are acting rationally and intelligently and ethically, and the same is true for insurers and providers. And one of the really important things that I like to note is I'm talking about the red arrows. I'm not talking about the providers or the patients. I think everybody's really acting relevant to the incentives that they have in this system. So with respect to patients and providers, there's a real problem about information. So we'd like to be insured. That's a really good thing. What that means is that the patient pays the premium up front and spreads the cost of their unexpected illness across both their lifetime and across the entire population. That's a wonderful thing because when you're sick, you don't want to be dealing with cost and price. You want to be dealing with focusing on wellness. The same thing is true for doctors. We don't want doctors thinking, I don't want doctors thinking primarily about cost. I want you thinking about treatment. I want you thinking about prognosis, and I want you thinking about how best to care for me. So it's a good thing that insurance protects patients and providers from price. However, it has a pernicious economic effect, which is that if the patient pays for their premium up in front, when they're actually accessing care, they're going to see it as an all-you-can-eat buffet. They paid the entrance price when they paid the premium, but they're going to access as much care as they want because they're not paying a price. So we have a challenge there to get quality information out to, cost information out to patients in a way that's reasonable and respectful of their position in the healthcare system. We also have challenges in information with respect to quality, where neither patients nor doctors have really the kind of outcome information we want. Outcome information about preferred treatments and outcome information about preferred providers. There's really no highly credible, highly consensus source of outcome information that's meaningful to patients and really even meaningful to providers in many cases, or I might even say most. So this lack of information for patients and providers is really another way that, because of that lack of information, patients and providers are seeking more and more care. And then finally, there's this incentive between providers and insurers. You'd think insurers would be in a position to negotiate very effectively for lower costs and pass that on to their customers. And certainly that happens in some cases, and insurers tend to be very aggressive negotiators in some environments. But let me suggest that there are some situations where their power is actually quite limited as well. If you look just at the hospital insurance market, the insurance negotiations between hospitals and insurers, think about it, this is an oversimplification, but as two kinds of hospitals that an insurer has to negotiate with. There are the large, usually highly paid academic medical centers, which often have market power and especially brand power. There are the specialty hospitals, and there are the geographically isolated hospitals, so the Nantucket Cottage hospitals of the world. Patients and, in fact, regulators often demand that these hospitals be an insurer's network, which severely limits the leverage that insurers have to drive down prices at these high-price, high-volume hospitals. On the other side, we have community hospitals and disproportionate share hospitals, which means that they have lots of Medicare and Medicaid business, which, as you know, are low payers. These hospitals know very well that the large academic medical centers are getting paid significantly more than they do for, in some cases, similar care, the normal childbirths, the appendectomies of the world. So their message to the insurers in these negotiations is, pay us more, close the gap, decrease the inequity between these payments for similar care. That there's some strong evidence that, especially for the the low acuity care is similar quality at different settings. So the insurers have limited tools to be able to really drive down costs in these negotiations. So when we're thinking about treatment for this diagnosis, the first thing that you want to think about is allergies, right? And so what allergies do the system have? So I think we all know what the allergies are in the system. The allergies are regulation. The allergies are, one of the symptoms of the allergies is if you start talking about reasonable conversations with your patients about end-of-life care and paying for those through the Medicare system, the allergy is, shortness of breath and speaking about death panels, uncontrollably. And that goes for lots of different other kinds of regulatory analysis. So regulatory options. So the approach Massachusetts took is 2 lines of treatment. Recognizing those allergies, the first-line treatment is really a light touch approach. It's increasing information, cost and quality information. And that's really the primary charge of my agency. We do a lot of work on asking the right questions around cost, and then answering those questions again in a way that's reliable and meaningful. We do information on a medical group basis, information on a hospital basis, information on a health plan basis, and different kind of insurance products. We look at both prices and total medical spending for cohorts of patients. And then we also look at quality, and that's an area that we're new to, but we're going to be working with the medical society and other stakeholders in thinking more and more effectively about how to speak about quality at a state level, at a population level and individual populations throughout the state, and then even providing more and more meaningful quality and efficiency information directly to doctors. And we look forward to working with the medical society about that. Plans and providers are also being asked to provide more cost and quality information, and Dr. Dunlap referred to that as well. On the incentive side, benefit design, which is about high deductible plans, limited network plans, and tiered plans are growing in importance. And of course, the success of those plans depends on the availability of information, so it's something that we're very focused on. And on the contracting side, Massachusetts is way out and ahead of other states in innovation in contracting. That puts a huge burden on you because you're forging new ground and taking on new risks and learning new skills. And I can't thank you enough for kind of taking those risks and really setting a new pattern for the country and how we can really build incentives that reward high-value care, quality and efficiency at the same time. It's no easy task, but we are well out in front. The research was released last summer that indicated that we have 35% of our members under management in what we call a global budget, where the primary care physician or the group is responsible for the total cost of care for those patients. 35% is at least 3 times, maybe 4 times as much as the national average in these kinds of contracts, and really another place where Massachusetts is a leader. So the second line treatment is regulation. So what do I mean by that? We're going to go with the first line treatment for several years. We're going to measure our success. And the first line treatment, as you saw, is not regulation. It's incentives, new approaches in the private market without a lot of heavy-handed government intervention. It's also a lot of information provided both by the state itself and also by private actors like hospitals, health plans, and so on. My agency is going to calculate the success of that. We're going to measure each year the total health expenditures in the state, again, looking at Medicare, Medicaid, and the commercial market. And we're going to see how fast it's growing. If it grows faster than what we call the benchmark, 3.6% a year, if it grows faster than that benchmark year over year, then the Health Policy Commission and other state actors get a new set of tools to start working individually with health plans, hospitals, and physician groups to control the cost of care. So only if the first-line treatment doesn't work do we trigger the second-line treatment of more direct government engagement in the form of performance improvement plans that are managed by, like I said, the Health Policy Commission. So what's the prognosis? Paul Krugman in the New York Times published a column about healthcare last week. He said the facts are striking. Since 2010, when the Affordable Care Act was passed, real health spending per capita, that is, inflation adjusted and per person, has risen less than a third as rapidly as the long-term average. Real spending per Medicare recipient hasn't risen at all, and real spending per Medicaid recipient has actually fallen slightly. So there are some preliminary early promising signs. David Cutler, who's a Massachusetts researcher and actually a member of the Health Policy Commission, published a paper in Health Affairs that attributed a significant portion of this slowdown in growth to fundamental changes in how care is delivered. More awareness of doctors and patients about efficiency and about choosing high-value care, and more investment in care coordination and really changing how medicine is practiced. And that's really happening nationally, and we're a leader in that area. So I'm proud to be part of an agency that's contributing to this success. I'm optimistic about the future, although I recognize that it has to be a continued commitment to transparency, to meaningful information that's shared in a way that is actionable for you. And I'm happy to say that I have a lot of great company, both in other state agencies that I work with every day, but also with the stakeholders, including the Medical Society. And I really appreciate you having me here today.